Hi, everyone. Um, I'm Ellie Mahoney, I think you all know, and welcome to today's Research America Alliance member web meeting. I think we have some guests today too joining us. Large number of registrants, and I think that's terrific, and it also speaks to the situation that we are in, the very complex situation we're in. But thanks to those of you who are Alliance members. We're so grateful for your partnership and for advocating together with you. We're using the Zoom webinar format, as you know, and that means all audience members are on mute just for now. But please feel free to type your questions into the Q&A box at any time during the discussion. And my colleague, Terry Schwartzbeck, will ask them during the Q&A portion of today's event. Speaking of today's event, our special guest is Dr. Georges Benjamin, who is the Executive Director of the American Public Health Association, and I am proud to say also a Research America board member. Georges, you were with us, I think, last in April, I believe, and in the early stages of the pandemic, and life has changed dramatically in many, many ways. So we're so grateful to have your insights again now on issues like the more transmissible versions of the virus and vaccines, vaccine distribution, et cetera, et cetera. So let me stop there and welcome you and take it away.
Thanks, Ellie. I guess everyone can hear me okay? Great.
Yes, I'm good.
So let me just talk a little bit about where we are and where I think we're going. So we've got somewhere around 23 million cases of this disease so far, and it's growing very, very rapidly. We've had over 384,000 deaths. And, you know, last summer, I was very concerned when we crossed the 200,000 death mark and thought we would be getting to 400,000 deaths. And we probably will clearly break that number of deaths because we're getting over 4,400 deaths a day on average. And that remains a real challenge for us. We're now seeing a virus that has mutated. Let me just point out the fact that these viruses mutate a lot, all the time. So this is not unusual. They can become more infectious, they can become less infectious, they can become more lethal, they can become less lethal. A virus that can become more lethal can become less lethal. So they change a lot, particularly RNA viruses. But in this case, this one has now become more transmissible. Not all strains, but we're seeing those strains now in the United States. And while we do not believe that it has escaped the vaccine, meaning that the vaccine we have today works, there is some early evidence that it is escaping some tests, meaning that there may be some more tests that are false negatives, even though people may have one of these strains of COVID. And I shouldn't say COVID, it's really SARS-CoV-2. But the end is in sight. You know, everyone keeps talking about the light at the end of the tunnel here. And we do have a roadmap to ending the pandemic. Obviously, maintaining the prevention tools that we have, wearing a mask, washing your hands, maintaining physical distance, and avoiding large crowds still remains the benchmark of managing this outbreak, even once we have vaccinations. Clearly having effective testing and contact tracing remains the core public health efforts that we need to continue to do. And we should not be doing a trade-off between our need to test and contact trace with vaccinations. There are some communities, in fact, where the disease is so prevalent that it's very, very different to do the contact tracing. But we do need to still do it as much as we possibly can. And then, of course, vaccination is the newest tool that we have in our tool shed to address this pandemic. So as we think about what we need to do to scale up the response, I know the Biden administration has certainly set a goal of 1 million vaccinations a day, and I strongly support that goal. And I think it's probably in many ways an attempt to under-promise and over-deliver. We're somewhere a little over 500,000 vaccinations a day now. And CDC has a nice curve showing that it's growing, and that's good. So we are beginning to take off on that. But I think if you actually do the math, we need to be around somewhere to 2 to 3 million vaccinations a day by early summer if we're going to reach herd immunity in time to really begin to open up. I'm very much concerned that we do this because my vacation's in July, and I want to make sure we hit herd immunity by then. Clearly, the administration has to utilize the Defense Production Act in order for us to speed up vaccine production and to ensure the adequacy of vaccine supplies. That includes, needles and vials and testing supplies, and we still need to have more personal protective equipment as part of this process. I've argued that we ought to be looking at how we can vaccinate 24 hours a day, 7 days a week in some communities. We certainly do have health facilities that are open 24/7, particularly some of the urgent care centers, some of the retail pharmacies. And so the ability to get vaccinated with the same prevalence and a capacity with fast food is certainly something that we ought to do. More reliable automated appointment systems are important. As you know, we've been using a range of appointment systems. Some of them have not worked real well, but doing this is going to be a centerpiece for us to get this stuff done. Right now, if you want to go to many physicians' offices and healthcare facilities, you go in the day or two before your appointment, you put in all the demographics, pick the time you're going to get seen. And in fact, if you have a co-payment, you can pay it that as well. And while we don't have to pay for these systems for the vaccination right now, all that other demographic data that can go into that system is very, very important to do. And the goal is for you just to show up, show who you are, roll up your sleeve, get your shot, do the waiting period for 20 and 30 minutes afterwards, and then go home. And we ought to be able to move the system much faster by automating it. And this is not rocket science. Right now, we can do this for concerts. We ought to be able to do this for vaccinations. And then, of course, doing efforts to reduce the amount of vaccine wastage. Vaccine wastage of this very, very valuable commodity is just due to poor planning. And we need to make sure that we address that very, very aggressively as we go forward. I would like to argue, that an all hands on deck for response is important. We've got FEMA, we got National Guard and the military, and we have a range of community groups that we need to get involved in this. Volunteers. We need to move some of those barriers, which I want to talk about in a moment. But rationale that the National Guard and the military have a lot of really important assets that they can give us. For some National Guard units, remind you that the medical assets are already in the community, probably worrying about and doing this vaccination effort, but not all of them. And so we can use them and scale them up. We have a whole range of other federal resources, communications, engagements, administration, that we can pull together and treat this like the emergency that it is to get our nation back at work. Increasing the workforce, the Commission Corps, the Public Health Service. More, I know they're using them now, but more utilization of the Commission Corps. Removing bureaucratic barriers to use volunteers. I've heard that some people that want to volunteer, but they can't get their police screenings done, background checks done. We ought to be able to rapidly scale up any background checks that we have to do to get our volunteers up and running as quickly as we're doing everything else. Remove the bureaucratic paperwork for service and vaccination, the same way we remove the bureaucratic barriers to create the vaccine in the first place. And that includes using anybody that can vaccinate. That means pharmacy techs, that means nurse practitioners, medical students, physicians, docs. A lot of docs don't give shots. We've forgotten how to do that. But a 20-minute video ought to help us figure out and remind ourselves on how to give those shots again. But we ought to get all vaccinators at the table as part of this process. And doing a much better job of supply line management. So that both the Trump administration has talked about moving all the vaccine that we've had in reserve out into the field. The Biden administration is at least leaks have talked about doing that. I think that's a very good thing to do. We always got to make sure that we have a second dose for people that need it, but we ought to be able to do this. We ought to be able to create a system and a supply chain that allows us to have the surety of vaccination, because what happens when you aren't sure you're going to have vaccine on any given day, then you're likely to hoard vaccine. If you're not sure you're going to have vaccine for that second shot, then the tendency is to hoard vaccine. And we want to take that out of the equation. So to the extent that people know what day they're going to get the vaccine and it's guaranteed to arrive and how much they're going to get, and that amount is guaranteed to be there, the minute we can assure that, the minute we are able to more rapidly speed up this vaccination process. And then the issue around priorities. Clearly, we've focused a lot on both paid and unpaid healthcare personnel as part of Category 1A and residents of long-term care facilities. But we also need to recognize that these priority groups, they're not a hard line between them. They're a gray area, so that we ought to be able to create appointment schedules that focus on the top tier priority populations, but that we ought to be able to have those second tiers waiting in line, either by double booking or having an appointment schedule where we can call people in and say, look, we've got a couple of extra doses of vaccine today. Can you get here by 6 p.m. so we can get this vaccine in the arm? We should not have anyone that wastes vaccine because there's not someone around to get the vaccine. And obviously, we're now talking about moving to people age 65 and older, particularly those with conditions that place them at high risk for the severe disease. So that's diabetes, hypertension, chronic lung disease, heart disease. Those groups certainly need to be vaccinated. And so Group 1A, Group B, and Group C ought to be out there, and we ought to make sure that those priorities are as flexible as we need to be and give local communities the flexibility to get the shots in the arm as fast as we possibly can. And then, of course, we have to deal with this whole issue of vaccine acceptance. That continues to be a problem. Surprise, surprise, even the medical care providers are less accepting of vaccine than we initially thought. Doesn't mean that they don't want to get it, but in many cases is they don't want to get it first. But we just remind people that millions of people have gotten these shots all over the world, and the consequences of getting the vaccine we've seen that the vaccine is very safe, and we know that at least in clinical studies it's effective, as much as 94-95% effective, at least Moderna and the Pfizer vaccines. So we should be able to affirmatively speak to people that people are getting this vaccine and they're doing quite well. Yes, some people get a headache. Some people certainly get a sore arm. People cannot feel well for a couple of days, but that's your immune system revving up. And that's what's happening when you have those feelings. And by the way, if you got COVID, and even a mild case of COVID, you get those same symptoms. And we want to make sure you don't get the severe problems you get from COVID, which includes severe lung dysfunction, brain dysfunction, kidney dysfunction, and even death. Part of building that trust, this is an ad of Tony Fauci. He's part of an ad campaign that the Ad Council just rolled out the door. It's a national public health education campaign to educate physicians and other practitioners around the safety and efficacy of the vaccine. But as we roll it out, we're going to have to continue to use other trusted messengers, address this anti-vaccine messages head on. The best way to address anti-vaccine messages is with the truth. We certainly need a robust social media campaign. And again, engaging these social media disinformation campaigns, which are very, very destructive to this process. And the Ad Council is going to have a $50 million campaign. They've already begun doing the creative work on that. Again, this video series with Tony Fauci is one part of that. They've raised about $37 million, I believe, so far for that campaign, and is part of a work that they're doing with a group called the COVID Collaborative. I'm certainly an advisor to that group, and we're looking very much forward to these ads coming out to really focus on the general public as well. And then, of course, ensuring equity. It's going to be very important to ensure equity in vaccine delivery. And that means enhancing vaccine-seeking behavior. That means targeting and education, again, through trusted messengers, addressing the misinformation. And let me also add structural situations where people are focused like a laser on the occupations and not necessarily people that, like in healthcare settings, where they may focus on the doctors and nurses, but they're not focusing on the maintenance workers that go in those rooms, or the food service workers who are also exposed to patients. We need to make sure we do that. If we do that, we not only will achieve equity by race, ethnicity, and gender, but we'll also achieve some equity by occupation, by getting those populations that are most at risk because of what they do. And I've always said that I'm gonna get this shot when the person who picks up my trash is eligible. When the person who picks up, sells me groceries at the grocery store is eligible, and then I will be more comfortable getting that vaccine, and I want to make sure that they get their vaccinations. So with that, let me stop, and I'm willing to take questions.
Thank you so much, George. As I have approximately 4 million questions, but I'm only going to ask one or maybe 1.5 and then turn to the many other questions that are coming in. You mentioned that from what we can tell, that this mutation, and the mutations happen all the time, has not escaped the vaccine trap, I think you called it, or the vaccine box. Do you have any information? Does science or history tell us anything about mutations that actually can do that? And if so, if they can escape a vaccine, what is it? Is there an expedited way to make sure that vaccine then becomes viable again, or effective again? Or what scenario would play out if that happened?
Sure. We do it every year. It's called the flu shot.
Yeah, but we do it once a year, right?
We do the influenza vaccine every year because it changes enough each year that the amount of effectiveness of the vaccine isn't as much as we would want. Now, as you know, what we do every year is that the scientists around the world capture strains of flu, and they test them, and they look at how those strains are genetically changing every year. And then the Southern Hemisphere has their flu season, and then the Northern Hemisphere, where we are, has their flu season. And so we're basing most of what we know on what's happening in the Southern Hemisphere from their flu season. And then we make the flu vaccine to mirror what we're seeing and anticipating from that. Now, sometimes the virus changes dramatically enough, even from the early spring to the time we actually make the vaccine, so that it's not 100% match. But every year we do change that. So that's our attempt to do that. There's a possibility, depending on how long this vaccine holds, that we may have to take this vaccine every couple years, every 3 years. We don't know yet, but we will know as we continue to track it. And as the virus changes, right now, I'm sure that there are scientists out there that are thinking about this. But the beauty of this is the mRNA platform that's used to create this vaccine means that we can much more quickly
That's great.
Convert. Remind you that influenza vaccine, for flu, we have to have chickens, they have to produce eggs, then we have to inject those eggs with vaccine, with the virus, and then there's a process to produce it. So it's a much shorter process, and that allows us to address this a lot more quickly.
Thank you. Yeah, because I think if it did mutate, then the impact would be much bigger, because this is so much more easily transmissible, right? So speed is so important. The one other question I wanted to ask now is, and I may have already said this, what length of immunity do people expect the vaccine? Do they have an estimate, just
Yeah,
a educated guess
we don't know.
for how long it,
We don't know.
we don't know. Okay.
The people are doing the studies now, and there are some evidence now that it certainly lasts at least 4 to 6 months. But just remind everyone that this disease first occurred. We first began to see it in January or so. It actually showed up in China a little over a year ago in December. And so our experience with this virus is very, very limited. And we've only been vaccinating since we started the research studies last summer.
So this hasn't been enough time.
Yeah, we don't have any light real world experience beyond the 10 or 11 months that, well, even less than that, 8 or 9 months that we've been doing this.
Wow. Well, I definitely have questions about the period before herd immunity and what we're hearing about ICUs and that kind of thing, but I'm going to defer right now. Terry, do you have questions for us from the audience?
I sure do. And Emily, I see you have your hand up. You can go ahead and unmute yourself if you want to ask the first question.
Thanks so much, Terry. Hi, Dr. Benjamin. This is Emily Lubwich from
Hey,
the Heart
Emily, how are you?
Association. Hey, well,
Yeah.
hanging in there. Thank you so much for your presentation. That's so helpful. And as you were talking about vaccines, it hadn't occurred to me before, but it sparked a thought, and I was curious if anyone's thinking ahead yet. I know we are just in the initial stages of the rollout. A little rocky to start, but has anyone at the collaborative or at APHA talked about, not to be too Pollyanna, but the opportunity here, as we think about vaccine hesitancy more broadly and opportunities to use the success of the COVID vaccine in stemming the tide of the pandemic to then encourage people about the benefits of all vaccines. And is it too early to be thinking about that? Are those conversations happening? Just curious. Thanks, Dr. Benjamin.
Yeah, Emily, no, absolutely not. And in fact, my advice to people that were looking at this early on, like the Ad Council, was for us to really spin a campaign before we knew what we were selling, before the vaccine actually rolled out. There was a missed opportunity. And that was the opportunity to educate people better on what a vaccine is, how are they generally made, why do they work as a therapeutic. And I still think there's a need for that kind of broad education. And I also think that we need to remind people that this is, of course, only one new vaccine, but that we're now also in many cases creating a vaccine debt. And what I mean by that is we have lots of kids who haven't gotten their childhood vaccines because they weren't going to the doctor because they've been sequestered at home. As you know, one of the ways we catch these kids is catch up for these kids is when they go to school. And so that's not happened. So quite frankly, I am personally today more worried about a measles outbreak next fall than a COVID outbreak next fall. So I do think, yes, we have an enormous opportunity for us to remind people that vaccines save lives and that that the success of this vaccine should help spur us to encourage people to get, influenza, shingles, childhood vaccines, their pneumococcal vaccine, et cetera, et cetera.
That's great. Thank you, Dr. Benjamin. Good to see you.
Great, thank you. So you mentioned the Ad Council campaign, and in response to Frank's question, I think the Ad Council is the one that was referenced. Can you talk a little bit more about that and some of the tools that are out there, or maybe tools that are needed to keep combating this infodemic of misinformation?
Yeah, they're just starting their campaign. As I mentioned, they did the video ads for health providers, primarily physicians, and there are a couple neat ads, but they're doing the creative work now, and I believe that soon they're going to roll that out. They've figured out how to focus on the broad population. There's a group that up in at the CUNY City University of New York that are focusing on messaging for vaccines. The de Beaumont Foundation, working with pollster Fred Luntz, have looked at some of the words that we should and shouldn't use in terms of trying to communicate vaccines to try to deal with hesitancy. the Reagan-Udall Foundation. I do sit on their board. We have done some work for the Food and Drug Administration to look at both communities of color and frontline essential workers, and to understand some of the hesitancy issues there. And again, just to inform our methods of communication. I don't know that any of us discovered anything new in terms of who was hesitant and some of the high level reasons why. But I do think that people are learning more and more how to communicate that more effectively to other communities.
Great, thank you so much. Another question that's come in, one hears that there are some sites at the end of the day, they have leftover surplus vaccine, and yet they don't have any scheduled appointments. So they call people they know, or they have to find people to give these vaccines to. Any thoughts about how this is going to be handled going forward and how the system controls these leftovers?
Yeah, again, we should plan for that. I think that's a planning issue. And I don't want to criticize anyone, but the truth of the matter is that it's poor planning. We know that people don't show up for appointments. We know that that's a phenomena. And so we should plan for it. And those folks that have put on the line, have people's phone numbers to call them in, or identifying people who are in certainly those first three categories. In any grocery store on any given day, you can find people who are frontline workers, people over age 65, and people with chronic diseases who are waiting in line. So finding them shouldn't be a problem. The real tragedy would be letting that vaccine go to waste. But we should plan appropriately. But when we have excess vaccine, we ought to give states and locals the flexibility to do categories 1A, 1B, and 1C. But we should properly, schedule that.
Terry, let me just ask a question that relates to that, and it relates to Research America advocacy. George, is there going to be a Never Again commission? And actually, Never Again has too many meanings right now. We have to change the name. But are people capturing these lessons in real time, these problems in real time? And is there going to be a commission formed to get at what we can do better next time?
I hope so. Kind of like the 9/11 commission after 9/11, and I sure hope so. And I hope that we look at how not just to focus on this disease, but we need to figure out how we build a really durable, sustainable public health system to identify any health threat that injures the community. I just remind everyone that we're dealing with COVID, and COVID's been terrible. But a little over a year ago, we were talking about the opioid epidemic and how it was devastating our communities. And 3 years ago, we were talking about the obesity epidemic and how it was undermining the health and well-being of our kids. And then prior to this, we had H1N1, we had Zika, we had Ebola, and every single one of those, we saw it coming, it hit us, we threw a lot of money at it way too late, and then the money went away before we had a sustainable system. And we got to stop doing that because it's costing us way too much money to do this. And we now know that every time we advocate for a little bit of extra money in public health and they tell us no, and we tell them, boy, you really want to invest in this because something bad is going to happen. I remind them that, yeah, we were right. Something bad was going to happen. By the way, this is not as bad as it could have been. There are a whole lot of other really, really bad viruses hanging out there, and bacteria that, antibiotic resistant bacteria that we haven't paid enough attention to.
And I think one of the frustrations is that our lead public health agency has its hands tied, and their flexibilities have been limited over the years through appropriations and authorizations, so that they get blamed for things they actually can't do in law. And I think that has to change as part of this whatever commission. We have to give CDC, we have to empower that agency. And anyway, I'll stop. I'll get off my soapbox because this is about questions. Terry, let me turn back to you. And how long do we have Can we keep you, Georges? Can
We're
you stay
good.
with us?
We're good for a while, yeah.
Okay, okay. Terry?
Great, yes. George Hill from Vanderbilt, you have a question and your hand up. You are unmuted if you want to go ahead and ask.
Oh, thank you very much. First, Happy New Year to all. And Georges, it's good to see your smiling face.
Absolutely.
Pleasure indeed. And thank you for all your work that you've been providing, information that you've been providing. I know you know that there's a tremendous hesitancy in some populations, and in the African American population, there's a hesitancy to taking the vaccine. I wonder if you could comment on two things. One is the reasons for that, and then what are some of the steps you see can be effective in overcoming that hesitancy and encouraging and being successful in having individuals be vaccinated? And again, thank you so much for everything you're doing.
You know, obviously people could continue to quote the Tuskegee study, which quite frankly, most people of my kids' generation don't even know about. They do know a little bit more about Henrietta Lacks, which was another issue, not the same category as Tuskegee. But the truth of the matter is that people are really responding to what happened to them yesterday. The fact that the way they were treated in the health system yesterday, the fact that they felt discriminated against, often real, and the profiling that's occurred. So I think at the end of the day, we've got to begin to create a society where we treat everyone with respect, and that's going to require addressing discrimination. It's going to, racism. We've got to deal with some of the structural systems we have in place that create that distrust. So some of the solutions, of course, are trusted messengers. During the HIV/AIDS epidemic, we wanted to convince communities of color that HIV/AIDS was something they should pay attention to. And so we got trusted messengers. Some of those trusted messengers were barbers, beauticians, people of faith, the churches. We engaged outreach workers. Now, doing the outreach workers is tough now while we're all sequestered in our homes, but that's going to be important. And now we also have a new tool called social media. And while social media can be a strong proponent for misinformation and when used purposely in the wrong way, disinformation, it also can be used as a strong tool and very effective tool to get the right information out there. And so we have to target it, using radio, using newspapers. We got to make sure that our public service ads are not at midnight or 1 in the morning when nobody's watching.
Right.
So I think there's a range of things we know how to do this. The science is there, but we're not doing with that intention yet.
Have you found in your experiences that individuals who are hesitant come from a wide variety of backgrounds? Some are professionals like ourselves, and some are the individuals perhaps working in Kroger's. Why is that? Why is there this wide range of individuals who are just hesitant?
Yeah. So and your point is well taken that, first of all, they're not anti-vaccine, they're just hesitant.
Yes.
And, there's lots of reasons. We've increased the number of vaccines that we're giving. And we've not done an adequate explanation as to why that's important. People think that if I get, all these additional vaccines, that somehow that's different than being exposed to the millions and millions of viruses that we get exposed to every day. We haven't explained that to people. When I mentioned earlier why we have to explain what a vaccine is and what the vaccination process does and how it differs or doesn't differ from natural infection. We have people, these parents want to do the right things for their kids. And nobody wants to see their kids getting, several shots at a doctor's visit. But we have to do a better job explaining and why the schedules are put together so that parents know that, you're coming in today to get your shots and here's why. And I got to tell you that the fact that we've shortened the clinical visit to such a short period of time, we aren't spending the time in the exam room that is necessary for a whole range of health education things that have to happen. And we've squeezed so much money out of the clinical enterprise in the name of efficiency that we're not able to hire the people to do this if the clinician can't do it. So I think that we have to really figure out what we want to do and put much more money in prevention. And if we do that, of course, we will be able to spend much less money on the sick care side of the house. So it's a way of rebalancing the equation. And I think that's going to have to happen. It will not happen simply because the economy or the system just happens. We have to make it happen.
You have to make it happen. That's such a good point. And I am seeing many, many questions coming in, Terry. And thank you, George, for that terrific question. Terry, would you mind?
Yeah, absolutely. Another question that we have here from our friend Chris Volpe. Some recent data from Science Counts indicates that 1 in 4 Americans believe a safe vaccine has no side effects. And that is even higher among minorities. So how do we address approaching these concerns of folks around side effects, especially as we hear differing stories about reactions?
So everything in life has side effects. You know, if you exercise too much, you get sore. You know, if you take aspirin, it can irritate your stomach. If you, you know, every medication, everything we do in life has a consequence. And what we have to do is tell people that the symptoms that and signs that you get from a vaccination are the manifestation of that vaccine working. You're getting inflammation in your shoulder because we put in a foreign substance in your shoulder, but it's working. That's how your body takes that vaccine and uses it to learn how to keep the bad stuff, you know, the bad organisms from attacking you. And so the fever, the headache, the sore shoulder, the fact that you don't feel good for 2 days is the cost of doing business. And we should, you know, we have to differentiate those minor side effects, and maybe we need a better word for it, from a bad allergic reaction, by which the fact that we've had very few of those, even though, you know, we saw a lot of those promoted in the media very early on, turns out that that's not a very common occurrence from this vaccine. And the people that, in most cases, that had an allergic reaction, they were people who had allergic reactions to other things. So there was a high risk that they would be allergic.
It's fascinating.
Great, thank you.
Oops.
Sorry, I thought I clicked my mute and I didn't. We've had a couple of questions regarding the children, teenagers, children under 15. What is the plan? Where are we with that? Is there a sense of the timeline? What's the state of those clinical trials, and how do we develop that, you know, herd immunity without making sure we get the young ones?
Yeah, I need to do one thing first. I'll answer that question, but I need to clean up my act or my wife will kill me. I have to mention that PAs can give shots because my wife's a PA, and dentists can give shots and dental techs because my dental friends will often kill me.
Yes.
And there are some communities where veterinarians, you believe it or not, can be brought in engaged to do shots. I won't touch that one too much, but absolutely. We do, like I said, we usually use all vaccinators. I know that both Pfizer and Moderna are looking at bringing studies down to young adolescents around age 12 or so. There are efforts to begin studies in children. I know there's an urgency to getting this done, but as you know, our practice has always been, and I believe it's a wise practice, that we start with people that can say yes or no to medical care, and that's adults. And so we do our studies in adults. And then once we've done them in adults, then we move to begin to go down the age group. And then, of course, somewhere in there, we look at pregnant women. And so it's important that that we do children, but it will take some more time. And I know that they're planning studies to do that as we speak.
Great. Another question. There's been a lot of talk about the 1 dose and the 2 doses. And is there any thought that a single dose vaccine might have less vaccine hesitancy? And are there any concerns about people not being able to get their 2nd dose or that becoming an issue? And that was kind of 2 questions. Sorry.
Well, no. The truth of the matter is that you know, if you just think about any kind of medical compliance, you get better compliance if you have to do it once, pure and simple. But the studies were done with 2 doses, and the reason I think most people are hesitant to change that is that there is a reason for doing what we call a primary dose and then a booster dose. That's the way we probably ought to explain it. And it was tested that way on purpose. Now I know the Brits are trying to do 1 dose, and we'll get some data from that. But I've argued that we ought to stick with the plan, because like anything else, if you move the plan around too often, then you won't get the outcome that you desire. And this is, you know, and don't get me wrong, we want to vaccinate as many people as fast as we possibly can, but we want to do that effectively. And what we know today is 2 doses is effective. If it turns out we give 1 dose and turns out that it's not as effective, then we've undermined our efforts. So we should follow the science. That's first thing. Secondly, we do know that at least right now, the Johnson & Johnson vaccine is slated to only be 1 dose. It's not yet approved. I know they released some data in the last day or so that shows that it's looking promising. And I know that hopefully sometime in the next month or so, they'll be able to, you know, at least the press announcements that they'll be going for emergency use authorization. So hopefully that will all work out. Having said that, it also hopefully is a vaccine that has less of a requirement for ultra cold storage, and very well because of the 1 dose and the ability to get to not require such more onerous storage requirements, that we can reach more people in particularly rural communities, inner city communities, et cetera. So from the perspective of the 1 dose regimen, help may very well be on the way in the next couple months on that as well.
I think that is important. I think what I heard you say is that when the vaccines that have been approved with a booster, stick with that plan, have the vaccine and the booster. If a vaccine is approved where 1 dose is only needed, that's great. And even better if the refrigeration requirements make it easier and more accessible. I think that's what I heard.
That's correct. And
Okay.
on top of that, we should still use the 2 doses. In other words, we're
Right.
going
We shouldn't give up on those
early.
vaccines. We
We're
need
gonna
all the
add that.
vaccines we can get. Absolutely.
Look, during the polio outbreak in the 50s, we had 2 vaccines, and there was a duel between the 2. And we went back from the OPV to the IPV and back and forth, and ultimately we ended up with the shot. But sometimes it takes a while to work that out.
Right.
In the real world.
That makes sense. I'm sorry, Terry.
Well, I was going to hand it back to you, Ellie, and see if you had any other questions of your own.
One more quick question. Georges, what's happening? It's a big question, but you can answer it as well as you want.
Okay.
I just am, we're hearing reports about diversions from one ICU to another ICU to another ICU, where they're triaging, and these life and death decisions have become real in some areas of the country. And part of me, I just don't understand that. Why the military MASH units couldn't be deployed, why there aren't tents, why there aren't ways to make new ICU space quickly, and how much of a problem it is, how much of a reality it is. Is it confined to only a few places in the country? Like, what's the prospects for us in the next 2 months or 3 months or 4 months?
We absolutely need to have the capacity to scale up, and many of the hospitals are doing that. You remember in New York, they set up what was the equivalent to MASH units. They brought in the hospital ships. It's a challenge, and it tells you what our hospital system was really unprepared for when this thing first hit. And of course, it hit in LA and it hit in New York. We were able to flatten the curve. People stayed home, but the tolerance for staying home and the travels that we've had over the holidays, we've always had a spike after every holiday, have just become cumulative. And yeah, people are having to make really, really, really tough decisions because people are not wearing, some people are not wearing a mask. Some people aren't, taking this thing seriously. We're still seeing places where people are having parties with lots of folks, and that's contributing to the problem. I know when I was practicing emergency medicine or running an ambulance service, it was not uncommon for us to have put hospitals on diversion. When we were having the many gunshot wounds in the Washington, D.C., when we were having an epidemic of gun violence in the city, we were frequently putting hospitals on diversion because they had just had too many gunshot wounds in the hospital. And now we're seeing the same phenomena, but with an infectious disease. And yes, we can scale up, but the rate limiting step is not space to put people. Even though you see people in the hallway, et cetera, stuff, the rate limiting step is healthcare providers to take care of them. And so that's what's limiting our ability, is primarily bodies with the skill and expertise to take care of these folks. So if we're serious about this, we're going to have to work, again, prevention. Wear a mask, wash your hands, keep your distance, don't get in crowds. And that's what we're going to have to do if we're really, really serious about protecting ourselves. The vaccine is an additional tool. And because this is Research America, let me add one other thing. The reason we've been able to do this so quickly is that we did not skip any steps on the research. But we've been doing this since the first SARS outbreak. They were very close to an effective vaccine from the first SARS outbreak back in around 2009 or so.
Yeah.
So what we're seeing now is the investment in science. That's why we were able to do this so quickly, because the scientists that live in our very neighborhoods, that we can't name other than Tony Fauci, that live in our neighborhoods, where the research is done from our academic health centers and many companies right down the street from most of us, though that research brought us a very novel mRNA tool that we can use for vaccines. And we'll be able to use it for cancer and all kinds of other things, this science. So when people ask, why should you invest in research?
Yes.
It saves lives. It saves lives each and every day, and people don't know their lives have been changed.
So true. And I'd add right now in real time, epidemiology, social sciences to get at vaccine hesitancy. It is all around us, and it's so essential to this response. We have kept you over time.
I'm good.
And I'd keep you for another 2 hours if I could. But I don't know. I think our webinar is kind of coming to an end in terms of our webinar time on Zoom also. So let me, and Terry, is there one more question that you'd like to pose, or should we?
Oh gosh, there's so many.
I know. And
I will.
Can we do one more, Georges?
Yeah, one more question.
One more question.
Okay, one more question. Let me pull them back up here. Looking to the future, do you see, Dr. Benjamin, a world where maybe we just wear masks all the time or more often? Have we learned something from this? Will it be more common to wear a mask when you're sick no matter what? Will it be more common to wear a mask when there's yet another pandemic running around?
This is America. When I was a kid, I always wanted to be like Zorro. So when I was a kid, I thought that, yeah, everybody wore a mask. And of course, for Halloween, we all wear masks. I don't know if we'll become a mask wearing society, but let me leave you with this. Last year, we had thousands of people that got influenza, and many people died. we've had less than a couple thousand cases of documented influenza, where people got very sick. I think that's right. But I mean, we've had almost no influenza. And why we have very little influenza? Because we're wearing masks, washing our hands, and keeping our distance. And that's the same experience that all the other nations in the world that have gone through this, again, that Southern Hemisphere experience in Australia and other places had. So while we may not become a society where you're required to wear a mask, I would predict that we'll be wearing masks much more often on things like planes and buses, just like they do in Asia. Folks in Asia wear masks a lot. And so I anticipate that we will have much more mask wearing. Probably won't be required. People aren't going to tolerate a mandate beyond this outbreak. But I suspect that we got to use those 25 masks that we've all bought with the pictures and the covers. I mean, we don't want to, so we're going to have to, the smiley faces and the message maps and the APHA Speak for Health mask, which I should have put on today. Yeah. Well, we'll have masks. People will be wearing them, and it'll be beneficial for the health and well-being of America.
Thank you so much, Georges, and thank you for this terrific presentation and Q&A session. Yes, I wanted to close by making a pitch that I don't need to make because you all know Steve Clemons, and he's joining us on Friday to disentangle the threads, the political threads, the legislative threads, the impeachment threads, to try to give us some sense of what this year is going to look like, or at least maybe the next month is going to look like on Capitol Hill. So join us on Friday. The inauguration will have happened, and hopefully in a peaceful way. Thanks again to everyone who's joined us and to our Alliance members. We so value you, and please keep in touch, call, email, text, and we'll be talking to you again soon. Thanks. And thanks again, Georges.
All right. Thank you.